Good evening, everybody. Namaste. I am Dr. Dhruvi Hasnani. I'm an endocrine physician at Rudraksh Institute of Medical Sciences, Maninagar, Ahmedabad, Gujarat. I welcome you all to a series of online virtual webinars wherein we are going to talk about a plethora of topics related to women health, related to women as such, women entrepreneurs, women leaders, and especially healthcare professionals in the field. Wherever we have to talk about, motivating females to take care of themselves. We've had the 4th of March, which is celebrated as World Obesity Awareness Day. We are also having the 8th of March, which is the International Women's Day. This is our attempt, a humble attempt, wherein we are doing this one of its kind he for she programs. We have invited all our mentors and faculties who are males and females to work together for the betterment of females and for them to be taking care of themselves, for the female health, as well as for all the healthcare professionals who are females and who want to do something to bring a change in the lives of all the women in our life. So with that, I'm going to introduce and hand over the digital platform to our very dynamic doctor, Dr. Vidisha Patel, who is a diabetologist from the city of Ahmedabad. Over to you, Dr. Vidisha, to introduce our faculties.
Thank you so much. Thank you, Dr. Dhruvi and Dr. Vipul, to give us this platform and a wonderful idea to bring up women doctors and to give them platform. So thank you so much. And to introduce this all things, I would like to invite none other than Rucha ma'am. So she herself is so dynamic. She is in for, physical health, motivational speaker. Wherever I go in all the marathons, I see her first, so she is there. And I would see no other than a woman inspiring other women than Rucha ma'am and also Dr. Dhruvi. So with that, also I would like to invite Dr. Narwaria, and he is a bariatric surgeon, so he's also going to join us very soon. And for
He has joined us. He's here.
yes, good evening, sir.
Good evening.
Yeah. So today our main focus is on the obesity and women health. So tomorrow we are going to celebrate Women's Day, and recently we celebrated World Obesity Day. And March is going to be for the women's, and Dr. Dhruvi said entire year is all for the women's. So before that, let me give you the basics. As we all are doctors, we know the basics, the BMI if we focus upon. So normal BMI is less than 18.5 is underweight. Normal is 18.5 to 24.9, and 25 and 29.9 is overweight, and above that is obesity and morbid obesity. So we will be focusing upon the obesity today. And as we have seen, women are slightly more prone to obesity than men, and there are many of the problems which are there which women face when obesity is there. So for that I would like to so there are many of the gynecologists we meet, and they have so many questions for the diabetologist related to women health, and most of the questions which we as a diabetologist have faced, so those questions I have just put it down, and most commonly asked questions we'll be focusing on, and we'll be asking both of the panelists. So first, my question is to Rucha ma'am. And what are the most common difficulties which we face or the complications associated with obesity in women health?
So thank you, everybody. Thank you, Dhruvi and Vipul, for organizing this, and Vidisha for being so pursuant and for that kind introduction. It's wonderful to be here. And I rightfully agree with you that, we are moving into an era of precision medicine. So we have started now thinking also of gender-specific medicine. So it's very important to approach all these disorders from a different viewpoint. So let's not call them disorders, but health-related or lifestyle-related issues. Because if we took care of our lifestyle, we wouldn't have a disease. So rightfully you've asked obesity, and in India, I think we would like to maybe rectify the BMI criteria. We have brought it down, as you're well aware, that now 25 and above, we like to refer as obesity and not 30. So that just tells us that at a lower BMI, we have much more fat in our body, so adiposopathy. And therefore, hopefully, Dr. Narwaria, who is the president of the Indian Obesity Society this year, we will make some changes. We will bring about that change as to we need to be more vigilant. Now, obesity, as you might understand, is a very, very active hormonal disorder, inflammatory disorder. And so it affects us right from top to bottom. So all the organ systems get affected. It has been linked to mental health changes, Alzheimer's, dementia. I'm speaking of the things we don't commonly speak about. So, of course, even in women nowadays, after menopause, we are seeing all this. We are all very well aware of the metabolic syndrome and diabetes, cholesterol, heart disease, fatty liver, high blood pressure. All of this is happening. But the uncommon things, the things that we may not think about, specific to women's disease, number one is increasingly seen Alzheimer's dementia. So we are starting to correlate this. And we may all have heard about how metformin and GLP-1 analogs are helping and weight loss is helping in Alzheimer's. So it makes sense that weight gain would cause that. Number two, something else to think about is obstructive sleep apnea is just as common in women as it's in men. Number three is cancers of the various reproductive organs and the breast. So obesity is one of the biggest risk factors. And if you could work on that, that would really, really help. Of course, infertility, obesity is strongly linked to PCOS and infertility. And the new entity or the new kid on the block that we call MASLD or the metabolism associated liver disease secondary to steatohepatitis, that is also an entity which we see in women, especially after menopause. So I think some of these have to be kept in mind. I'm not going into all the mechanical and skin complications because, that's a whole plethora by itself. So arthritis, osteoarthritis, skin diseases, acne, all of these can be linked to obesity. So I think the list is endless, but I just hope I've given some food for thought so that audience can also think
Yes.
about these unusual things. Yeah.
Yes. Thank you so much, ma'am. So talking about menstrual irregularity, so we see nowadays girls having their periods very early because of the foods outside, I guess, the fatty foods which are there, and the obesity which nowadays is there in the young girls also. Menstrual irregularity is very common right now. So is there any correlation if the reduction in the weight is there, but not the ideal reduction, any improvement in the ovulation or the fertility if it is seen?
Yeah. So of course, yes, certainly we know that obesity is a state of insulin resistance. So if we were to get down to the nitty-gritty, we know that being overweight or obese leads to an insulin resistance at the level of the skeletal muscle, at the level of the liver, and similarly at the level of the ovaries as well. And this insulin resistance does not allow the entire cycle wherein we make hormones from the pituitary known as FSH and LH, which are then in turn supposed to stimulate your ovaries to make estrogen and progesterone work in the correct, 15-day, 14-day, 28-day cycle that you need for your periods. As a result of this, what happens is you're making these empty cysts in the ovaries. So instead of making one cyst, your ovaries get pushed to make multiple cysts. And this is what leads to polycystic ovarian syndrome, which leads to a low state of estrogenism and progesterone, but a high levels of testosterone. Hence, the clinical diagnosis is plenty. If the woman has irregular periods, she has signs and symptoms of higher or excess male hormones, what we call clinically as hyperandrogenism. We can make a clinical diagnosis of polycystic ovarian syndrome. Now, the easy answer would be just to give them birth control pills and fix it. Their periods become regular, acne gets better, hair gets better. But you want to fix the problem from the roots, So you want to जब बोलते हैं ना जड़ से हमें निकालना है. So we want to fix it from the roots. So जड़ से कैसे निकालेंगे? So you have to fix the insulin resistance. Maybe for the short duration, you could use metformin and testosterone blockers, but the answer would be, weight loss, lifestyle changes, and so on, So that is what I would say. So this will lead into infertility. It's going to lead to anovulatory cycles, problems with pregnancies, gestational diabetes, and diabetes in the long term. So just, I don't know, Dr. Narvaria wants to add to the previous question you had. He was just.
Yeah, he's there. Hello?
Dr. Narvaria, you want to add to the list of complications with obesity?
Oh, if we start from head to toe, there are plenty of them. But I think if you talk about only women health, the major problems are menstrual irregularities, PCOD, infertility, uh, even certain kind of malignancies which are there because of obesity. that includes endometrial carcinoma, cervical carcinoma, breast malignancy. So these are few of them, and definitely the diabetes-related complications, which hello.
Yes, yes, you're audible.
Yes, are you able to hear? Okay.
Yes, yes.
So there are many such illnesses, hypertension, diabetes, hypercholesteremia, and even the pregnancy is usually complicated when they are obese. There is a high risk of premature death of the kid, the neonate, and there is a risk of a lot of pregnancy-induced complications like preeclampsia, neclampsia due to obesity.
Right. So, sir, I would like to ask you a question that before taking patient for bariatric surgery, before that, what all the investigations we do for the patients, what lifestyle modifications before and after, what do we advise, and how are the outcomes for that?
See, we do a complete health check that includes a CBC, LFT, RFT, serum creatinine, all viral markers. We do even nutritional assessment by doing a TIBC, iron level, vitamin levels, and everything. And after that, we do even X-ray, ECG, echo for the fitness point of view, and we do ultrasound to see the gallstone and fatty liver and size of left log and the level of fatty liver. So when the liver is very large, sometimes we put them on liquid diet for some time, maybe in medical therapy for weight loss for some time, and then we can take them for surgery. These are for people who are more super obese or the BMI more than 60 plus. So these patients, sometimes they have edema on the abdominal wall. You can't do laparoscopic surgery on these patients, and we have to optimize them before surgery. Similarly, we need to check their sleep apnea status because many of them, they are having severe sleep apnea. If they are sleep apneic, we have to even optimize the patients by giving them CPAP or BiPAP, depending on the severity of the sleep apnea. Lifestyle modification, most of patients who come to us actually gone through different type of lifestyle modifications, and when they fail, then only they opt for this surgery. Like today, I have a patient. She said, "I'm tired of doing gym and exercise and diet since years, and I can't. I'm not getting good result because of that," and she opted for surgery.
Right.
So I think Rucha is doing fantastic job. She make them run.
Yeah.
And
And do
she
you
motivate
advise
most of us, including me.
GLP to the patients post surgery?
Not so much, because after gastric bypass, usually oral semaglutide is not that effective. We tried using it, but it is not as effective as injectable. I still used dulaglutide to few of my patients, but that is mainly for some weight maintenance, not the weight loss. After bariatric surgery, to lose weight after 2 years, it is very difficult. Most of
Right.
these, once they stabilize after reaching the optimal weight loss, they don't lose weight irrespective of whatever you do. Me and Rucha, when we worked together, we tried many methods. We can just help them reducing 5-10 kg, but that is not enough when they are morbidly obese.
Morbidly, yeah.
So
Yes.
many times they have to go for revisions.
Right. So we have Dr. Dhruvi. She has raised the hand. She wanted to give some insights from her side also.
No, I have a very interesting
Okay.
question,
We wanted to hear something new from you also. That's why I said
No,
that.
I feel so interested with how Rucha ma'am and sir is answering. But I have this question: uh, is a surgical intervention or a pharmacological intervention amongst female of different age category more acceptable now than it was a decade earlier, or are these females, they are more proactive rather than reactive these days? Is that the scenario, ma'am?
Yes, I think someone may have to call Dr. Mahendra. I think he got disconnected just to make sure he's able to rejoin. Yeah,
No,
he's rejoined. Yeah. Yeah, he's just
back.
joining.
Actually,
Yeah,
I
yeah.
don't know
So I think,
why
yeah, so
exactly.
that's a very tough question. And Dr. Mahendra might have a little bit more insight into that. What is the social? Are you there, Dr. Mahendra, with us?
Yeah, he's there. Yeah.
Yeah. So
Yeah,
Dhruvi has
yeah,
just raised
I'm
a question
listening you.
about the social acceptance of bariatric surgery then versus now. So I think, yes, certainly, people, there is a huge push for wellness nowadays. The wellness industry is booming. So people want to look good, feel good, and they are willing to go to any measures. It starts all the way from seeking not just lifestyle changes, hiring the best fitness trainers, yoga, Zumba, taking semaglutide. There are so many more people who come to you directly and ask for, I'm sure you all experience about Ozempic, Wegovy. They have already taken Rybelsus on their own, you know. So very often semaglutide, that's what we're talking about. So we are seeing an increasing wave of this. I would say yes. Surgery also, I'm sure Dr. Mahendra would be he would be able to speak more as to what is the surgical part of it. But yes, for me, certainly more and more women. In fact, we have done an analysis. We see more women than men for weight loss. So it's very interesting, and for cosmetic
Yeah,
reasons
true.
alone, not for yeah. So Dr. Mahendra, what is your experience with
you're
surgery in
completely
that
right.
sense?
Yeah, yeah, I'm totally agree with you and aligned with your review, because even 70% of my patients are women. It is very high, 70%. I think worldwide also, the women are more who are opting for bariatric surgery than males. And I think they gain more weight after pregnancy, and once they are busy in their
Menopause.
household routine activities. I think that one reason, I think that they don't give priority to themselves, they give priority to husband, family, kid, and their own health is the last priority. And by the time they think about it, it is too late, and they become morbidly obese, and then they will try to run here and there to find the solutions, maybe a medical management or surgical management.
Right, right, right. Hello.
Yes, Vidisha, you're
Yeah.
audible.
Yes. So, I wanted to ask Rucha ma'am that during menopause, obesity, what are the complications more associated with menopause, and how do we treat that? Because there is increase in the fat mass and it is associated with menopause. So obesity
Yeah. So I think
and
so.
hormonal
Menopause
changes are
is
also
very,
very
very
much there.
tricky.
Yeah.
Yeah. Menopause is very, very tricky time for us also. When we see the patients, it becomes much harder for us to get them to lose weight. So not only is it that menopause is a time when they are going through all these changes, but they're also gaining weight without doing anything. We always hear women complaining that they haven't changed their diet, they haven't changed their lifestyle, and still what happens is that they're gaining this weight. And sometimes, as you rightfully said, it becomes a lot of fat gain. So it all sits around the visceral area, the central part or central obesity, what we call. And that's the reason why they also get the increased metabolic complications. So heart disease, cardiac attacks, cholesterol, pre-diabetes turning to diabetes. So all of these things happen. How do we work with it? So really, I mean, it's almost like I joke when they come in that you now have to live on love and fresh air. That's going to be your diet because और तो जो भी if you खाना सूंघ भी लोगे तो वजन बढ़ने वाला है. So it's not that we can expect everyone to be marathon runners or walk 20,000 steps a day. So you have to be realistic. And in fact,
Right.
if someone has an unhealthy lifestyle, I'm always very happy because then we are actually able to get them to lose weight if we make them even do minor changes. And we are fortunate to have our dietitians who have been able to really work well with them and identify making these micro habits. So I think number one step would be realistic goal setting in the menopause. That, listen, if you need to lose 10 kgs, it might take you not 3 months, 6 months, but the entire year. But even considering that sometimes it takes us the entire first month to get that scale to budge. So we just set like 5 to 10% weight loss goals for a much. Normally we do that in 3 to 4 months for most of our population. That's our goal setting. But if the woman is in menopause, then we will always say, let's keep it realistic. And then working on every little thing, teaching them calorie counts, complex carbohydrates, micro habits, all of that becomes important. Because it really does affect their mental health, their daytime fatigue, their sleep, all of that. So I think menopause is a big challenge. Yeah.
And any specific diet do you advise, or it is an individualized diet?
So of course, everybody is a little different. You know how Jawar behaves in you or Ragi behaves in you may not behave in me. And someone may do well with a high protein diet. Someone may do well with a new thing that's popular on TikTok nowadays, the 30-30-30 diet. So it depends on, so what works for you is different from others. But a question would be, if you were to ask me what is specific in menopause we use, is we pretty much do end up having to use like metformin in a lot of them, because very often we find very severe insulin resistance. at least for the short term, 20 to 30, days. Then we might do it again for so repeat maybe 3 to 4 months. We work on fat loss. The second thing in menopausal women, that not cardio but strength training works better. So
Right.
including strength training early on in the program. And number three is of course changing them from straight carbs to complex carbs, reducing carbs by 10 to 15% from whatever they were consuming, and increasing protein. Now, other things we have to focus on during menopause is sleep. They're always having sleep disturbances, not sleeping well, which adds, to the stress, the cortisol, so all of that. Because right now, of course, the hormones cannot be replaced, but we can work on other things. So magnesium, electrolytes, all of these things, vitamins should be replaced. So doing these few specific things helps. And then the last but not the least is, of course, they have to lage raho, consistency. You can't give up. You can't get, oh my God, I'm not
Right.
losing weight in 1 month. You have to think I did not gain weight this month. So positive reinforcement is a big, just motivating them, keeping them in the game is very important.
Yeah.
So I think
Right.
those are few of the tips I would say. Yeah, but diet absolutely. You have to keep on changing. You have to keep on showing them new tricks, something like that.
Right. Thank you so much.
And I think
yeah.
Rucha has its own there is a program called RR, Run with Rucha.
Okay.
I mean, I like it. I think we'll start that program.
You can,
yes.
yeah. From tomorrow, from Women's Day, we can think
Yes,
upon that.
let's launch it. And Ribs is
Yeah.
going to sponsor it. It's going to be
Yes.
RRR.
Yes.
Done, RRR, and that will be triple R from our side.
Triple R,
A
yes.
triple-
So yes.
See,
Now
Hetty has also
Narvara,
joined. She's excited. Yeah.
So Narvara sir, as we always we talk about diabetes to most of our patients because we are diabetologists. And what comes to a patient is like, if we get bariatric surgery done, diabetes chala jayega, kab chala jayega, kaise chala jayega. So this is the most common thing. Thyroid chala jayega, whatever BP chala jayega. So how do we convince the patient what are the outcomes and what should we expect from the bariatric surgery and the remission of diabetes post bariatric surgery?
See, whenever we opt for surgery or when we offer surgery, we ask them what is their expectation from us. One is they should decide the priority: weight loss, conflict resolution, and everything. And depending on that, we customize the surgery. I don't want to have 100% weight loss after in any surgery wherein person will reach to near normal. Even slightest overweight, because any program wherever we have weight loss, there will be significant muscle loss, and gaining muscle back is next to impossible, which Rucha must be experiencing, because people lose weight and they lose their muscle mass. They're happy about it, they lost weight, but nobody checks that how much is the fat loss and how much is the muscle loss.
Yes.
So we do a surgery, and depending on that, we decide the surgery. And this diabetes resolution, yes, I always tell them it all depends on the severity of diabetes at the time when we are intervening. So we always do certain tests to check their diabetes severity, mild, moderate, or severe. Then we have set of investigations we do. We do home IR, we do C-peptide levels and stimulate C-peptide and many other investigations to see the beta cell function. And then we decide, and then we tell them that what percent of people will get their resolution in terms of stopping the medicines. So when the diabetes is less than 5 years, young patient, no insulin, yes, they will respond almost 100%. 5 years with insulin, yes, the chance is almost 95%. And those who are 5 to 10 years, the chance of resolution is about 85 to 90%. And longer than that will be even lesser than that. We always tell them that, yes, we will help you reducing, but at the same time, you need to maintain your muscle mass, because muscle mass is the most important part after bariatric surgery, which will reduce. Otherwise, if you look at the fat percentage and muscle percentage, the ratio will get changed. So fat percent will remain still high because they lost their muscle mass and they don't do so well. And the slightest weight regain will bring the diabetes back. So if they want to maintain, they have to do lifestyle modifications. They have to maintain their muscle mass. They have to reduce the carb intake. Carb intake is a major problem in our country, because most of these patients, after getting bariatric surgery done, they develop a craving for carbs, because there is an acute surge of insulin after any carbohydrate diet. That will lead to more craving for the carbohydrates. So they keep eating, and many times the people keep. I've seen patients keeping the sugar tablets in their pocket because they are having craving. They'll take a sugar pills or
Right,
sugar. So that is not good because you develop hypoglycemia in response to these kind of sugars which they eat. So diabetes, yes, the publications suggest that it is resolved almost in 95, 85 to 95% of patients, but it all depends when we are intervening.
intervening, yes. And one my question is to both the doctors. Apart from weight monitoring the weight and calculating BMI, what other factors and parameters we have to look for when the weight reduction journey we are doing for the patients?
So yes, I think that's very important is that, let's not just focus on weight as a number. In
Yeah.
fact, obesity in India is not even yet being classified as a disease.
Diseases.
In the US also, it took a while for them to give it an ICD code before you could bill for it. We could not even bill for it. Even now, obesity is not covered by most insurances or health schemes. Therefore, there's a stigmatization. So we have to stay away from that. But certainly it would be helpful to think of obesity as a disease because it would help in getting some insurance coverage. And more doctors would think about addressing it to the patients. Very often in our busy practices, we don't have that time to think of weight as being the number one reason causing everything. So therefore, the outcome should be health. I absolutely agree with that. But we have to start with the baseline, the roots, as we say, the roots of obesity run deep is a nice thing that World Obesity Federation has put this time. तो हम जो बोलते हैं ना जड़ से निकालना है, that is important. So yes, so when we start talking to them, we always do a goal setting, not just for weight loss, but what is your target? Why are you here? And they'll say, my parents had diabetes, I want to prevent it. Somebody has infertility. Somebody is just feeling bloated, cannot tolerate food. Muscle gain or muscle loss, as Dr. Mahendra pointed out, some of them have come for a good body. Nowadays, the youngsters, it's very encouraging to see are coming in for just fitness, overall health. So I think that's really, really encouraging. So all of these parameters should be looked at. So when we start our patients on any program, we certainly do all their body fat and composition measurements. We have the texting machine in the office. We also do for the older patients, we are doing the grip strength, for example. So we can kind of objectively monitor muscle strength and function and not just muscle mass. Because it's very hard to gain muscle. To gain even 2-3 kgs in a year is a challenge at any age. So therefore, better to make the muscle stronger is what we focus on also. Then, of course, we are doing the baseline blood testing, looking for all thyroid, cholesterol, diabetes, insulin parameters, liver enzymes, calculating fatty liver index. So we do collect a variety of things right at baseline. And then what we need to be incorporating more and more is also doing some form of surveys for their mental health, emotional health. We do a very basic thing about how many hours are you sleeping, what is your stress level, because the minute you ask too many questions, the Indian patient really doesn't like invasion of privacy or thinking, why is she asking about my mental health? But we do some baseline surveys. And then we do it again at the end of every 4 weeks, we kind of reassess as to what get better. And we can reinforce that positive change in them also. That, hey, listen, once you've cleaned up your diet, how are you feeling in this area when you first came in? We will, on the body composition, my staff will give them a scorecard or they give them a certificate. They make a little medal thing. Hey, you brought down your fat by so much. You
Motivate,
did so
yes.
much. Yeah,
Yeah.
keep motivated. So I think those things make them feel better. Yeah.
Right.
I
So
think to reduce the stigma of obesity, we should change the name, and that is what proposed by researchers and even our organization. Now, the new name which is coined is adiposity-based chronic disease (ABCD) is the new term. So I think in future we'll be using only ABCD as a disease, not obesity, because obesity is a stigma. People don't want to
Stigma,
talk about
yes.
it, don't want to listen. So I think this is time now to change the name to
Right.
ABCD, that
Right.
adipocyte-based chronic disease. And once it is a chronic disease, people will opt for treatment,
Right.
just
Right.
like that.
Agreed. So, any quick pointers which you would want to share with all the doctors when we see patients, like specifically women with obesity? And simultaneously, I would like all the doctors to put in their questions in the chat box, so both our doctors can address all the questions also after that.
So Rucha first.
Yeah.
Okay, yeah. All right.
Women's first.
So yes, I would certainly
Women
say
first.
that
Women's first, yeah.
always, yeah.
Yeah.
And then, so yes, I would say, yeah, certainly I have a message to give to the women is that, the task may seem daunting. We feel that we have so much to do and we have to lose so much weight, but don't need to think of it in those terms. You need to start somewhere, work on one of the things and, try to focus on that and do everything possible. Don't think, "Arre, ye karna padega, wo karna padega." You have to go at it with all your heart, with everything you've got and really stay motivated and just do it for yourself. So I always say that focus on personal best as your goal. Don't do it for anyone else. And we are all here to help and suggest. There's so much information out there also. So I would say start with maybe weight can be very challenging to women. We don't feel good the way we look or something. But really focus on health or focus on something that can work for you. So like start with replacing one meal of the day with a healthier meal. Start walking 10 minutes every day. You can just start with 5 Surya Namaskars, 5 yoga breaths. It doesn't have to be that you have to do a whole lot to get the benefits. Even though we have this 150-minute rule and now they're saying 300 minutes of exercise per week, I would say that even starting somewhere and keep on moving is more important. So, like as much as possible, we have to incorporate those healthier habits. So our clinic motto is, a little goes a long way. Just take that first step today. So that's what I keep on trying to tell people is that you have to first walk to run. So let's start somewhere.
Very true. Very
Yeah.
true.
Yeah. So Dr. Mahendra, over to you.
Yeah. So I think we should give message to society that we should catch them when they are starting obesity. That is the time they can go back to normal. And we should incorporate some exercise in any form, whatever you like, whether you like dance. For women, a dance is a good exercise. Swimming is a good exercise they can enjoy. And I think they should think that they should at least spare 1 hour for themselves every day, because rest of the whole day, after 18 hours, they are working only for the family is not sufficient, because ultimately that will take toll after a few years, and they'll not be even fit to do exercise. So they should do exercise regularly, reduce the weight when they are overweight, not when they reach to a certain level of obesity. And I think get motivated by people like Rucha. Should have friend like Rucha.
Yeah.
And
Yes.
those who are morbidly obese, they can't do anything. They can always opt for bariatric surgery, which is very, very safe nowadays. We discharge patients same day nowadays, and there's hardly any complication which we have seen in last so many years. The number of surgeries which grows now thousands in the country. We do almost 20,000 surgeries a year in the whole country, and every center is doing fantastic. And we are very, very focused on outcome, because we don't want bad name of the surgery, and that is why the bariatric surgery has grown worldwide, because we minimize the complication rate to less than 0.1% for the mortality, and the morbidity is less than 5 to 6%. So
Perfect. So thank you so much. Thank you, Dr. Rucha. And we have so many questions. I can see so many hands raised.
hands
So
up,
yeah. So we'll start with Parul, ma'am. Can you please unmute, ma'am? Yeah.
Yes. My question to Rucha ma'am, is there any correlation of the blood cholesterol or blood lipids not with the body composition, fat composition? Is it so that this blood cholesterol level will be normal, but the fat composition in which there is a more fat? So what is your view on that? So nowadays,
Yeah,
I
so
heard not been correlated with your body fat. Your cholesterol level is not correlated with your body fat. Is it
yeah,
so?
so what you're talking about is an entity. So there are two ways to answer this question. Number one is you said the body fat is more, but the cholesterol is normal. So these are people who we also call as a class called as MHO, or metabolically healthy obesity. And very often they constitute less than 10% of the overweight or obese population. And we will see that in spite of having high BMI, high body fat, they do not have insulin resistance, they are insulin sensitive. But what we have seen in studies also that it's a matter of time before they will convert from insulin sensitivity to insulin resistance. Cholesterol, to a huge extent, is determined by your family genetics. So I think thank you for raising that wonderful question. Because even though it's a huge part of metabolic syndrome has a low HDL and a high triglyceride, which is linked to insulin resistance. What you are maybe asking me about is a high LDL cholesterol. Now, the LDL
Of
cholesterol
course.
and the non-HDL, which is very atherogenic, this comes from your liver. It is mainly synthesized in the liver. I would say about 80%. Less than 10% of cholesterol is dietary cholesterol. In the case of blood sugar, as we always say, 50% of sugar is from your food and 50% is only from your liver. So cholesterol to a huge extent. Now let's go to the other side where somebody is obese and they have high cholesterol. They need to be put on a statin. Even if they lose 20 kgs, very often the cholesterol does not go down. So this is also, if the cholesterol is high and if they are obese also, I still need to treat them. Just treating obesity does not fix the cholesterol. So very important to keep in mind. Very often they'll think they lost 20, 30 kilograms. But if the family history is bad, if the lipoprotein is high, you can get other surrogate markers nowadays. You would still consider treating their lipid profile. So very good question. Thanks for that, Dr. Parul.
Thank you. Thank you.
Yeah. Thank you so much. Thank you, Parul ma'am. Now we have Dr. Vipul. He wanted to ask a question.
You already answered about the healthy obesity. That was I am about to ask. Now I will ask. There are many female who are having gestational diabetes nowadays, and most common reason being late pregnancy and obesity before they conceive. So how would you address that issue in our country right now? That what should be the preconceptional goal for the fat percentage, for the BMI, and for the lifestyle to prevent this GDM and followed by type 2 diabetes in later life?
Mm.
Yeah. So as we've rightfully spoken that, unfortunately we only go by BMI, but we will have to move away from that and try to start focusing more on body fat numbers. Hopefully it'll become easier and easier to get body fat numbers. So currently the criteria is a little bit higher on the body fat compared to our Caucasian counterparts. So more than 25% body fat in men and more than 30% in women is considered to be obese. Okay. And these are the numbers you would work on. So just BMI wise, of course, we've already set the criteria that you want to be below 23. And hopefully that should correlate to a reasonable amount of body fat. But we see very clearly we have such a huge amount of lean PCOS and we find the body fat very high to the tune of 40%. So if you have a history of PCOS, if you have a family history of diabetes in your mother, or if you have a family history of gestational diabetes in your mother or family members, then you know that you are high risk. This would be a signal to teach your younger daughters, whoever's around you, your nieces, your neighbor's child. This is our call to action that we need to kind of tell them that you need to start getting healthy now. They need to be eating clean foods. And if you start early in your teens and 20s and avoid junk food, avoid the late night. I mean, we have so much easy access to the Swiggies and everything of the world is making
Yeah.
us eat so much junk food. And we are shocked to see body fat percentages of 44% in BMI 19 and 20 and hardly any muscle. The muscle is missing. So I think these are the numbers we would look out for. And if you are suspecting PCOS or insulin resistance, you should screen for it. And that might hopefully give them a call to action also. Yeah.
Yeah, they are called thin fat people.
Thin fat Indian phenotype is
Yeah,
the big one. Yeah.
Phenotype, yes.
thin fat people. So those who are normal weight or thin doesn't mean that they are fit. That fat percentage decide their commodities.
Hmm. Right. Any other questions? Dr. Dhruvi
It
and
is
Yogesh.
often a very, we are talking about female health and we are talking about obesity in women. How difficult it is, Mahindra sir, as a male person, bringing it up to a female that, obesity is your concern. And a lot of our listeners who are female doctors, all of us are either physicians or diabetos. For us as females, might not be so difficult to bring it up to a female कि भाई तुम्हारे वजन
Comfort
घटाड़वानी
रहो.
जरूर है. But those male counterparts, those physicians might not even be bringing it up, to their female patients. कि भाई, you are obese and you really need to do something about it.
It is a difficult challenge to convince a female patient for bariatric surgery, but usually they come to us when they get tired of everything, and as a last resort when they feel and they can't see themselves in mirror, because somebody who was I operated a ramp walk models, I operated beauty queens, even the patient participants for bariatric surgery. Once upon a time, they were models and they gain weight. So just imagine the psychological challenge which they are facing at this stage, and they come back for bariatric surgery. So I think people are opting. Earlier days, the females are not decision makers, but nowadays the females are strong, and since they are working women, they can take their own decision and they decide. Otherwise, the female was last priority in a family which is a male predominant family, which is not good. And I see this problem in older age of women who are like retired people or old age people don't give importance to their weight loss. They don't even take them to a doctor for medical weight loss. Forget about bariatric surgery. So that percentage is very low unless until they have severe pain and doctor suggests them not to do a joint replacement surgery because the weight is too much. Then only they'll opt for bariatric surgery.
Right.
Thank you for answering my question, sir.
Thank you so much. And
It was a
any
difficult
other-
question.
yeah,
Actually.
right. Any other questions do we have? Or else we'll hand it to Dr. Vipul.
So yes, it is a burning question. So આપણે અમદાવાદમાં છે, ગુજરાતમાં છે, તો થોડી હું લિબર્ટી લઈશ કે ગુજરાતી ભાષામાં પણ થોડી વાત કરીએ because our
અમે
audience
નેતા બનવાના જ છો તમે, ટિકિટ લીધી જ છે એટલે તમે બરાબર ફ્લો માં જ છો.
So when we are starting this program and we were searching કે આપણે સ્પીકર તરીકે એવા લોકોને લઈએ કે જે નેશનલ ઇન્ટરનેશનલી એક્લેમ હોય, so we need not to go too far. આપણા અમદાવાદમાં બેસ્ટ ફિઝિશિયન બેરિયાટ્રિક ફિઝિશિયન એઝ અ બેરિયાટ્રિક કન્સલ્ટન્ટ અને સર્જન બંને છે જ. મહેન્દ્ર સર અને રુચા મેમ આર ઓલવેઝ ધેર ફોર અવર ગાઈડન્સ એન્ડ અવર મેન્ટરિંગ. અને ડોક્ટર ધ્રુવીએ જે સ્ટાર્ટ કર્યું છે કે ફિમેલ હેલ્થને ઇસ્યુને એડ્રેસ કરવી અને એને એક પ્લેટફોર્મ પર લઈ જવું અને સાચી સાયન્ટિફિક સલાહ આપણે મેળવવી, that has been executed excellently. So I would say all the participants કે જેમણે જોઈન કર્યું છે અને આ વેબિનારને આપણે સોશિયલ મીડિયામાં પણ આગળ લઈ જવાના છે, ત્યાં પણ એને કન્ટિન્યુ સપોર્ટ મળતો રહેશે. સ્પેશિયલ થેન્ક ટુ અવર પેનલિસ્ટ ડોક્ટર મહેન્દ્ર સર એન્ડ ડોક્ટર રુચા મેમ કે જેમણે તદ્દન ઇઝી લેંગ્વેજમાં અને વોટ ઇઝ મોસ્ટ સાયન્ટિફિક એન્ડ મોસ્ટ રિસન્ટ ડેટા એને આપણને આપ્યો. Dr. Vidisha wonderfully moderated this session, and again congratulations to Dr. Dhruvi for this wonderful idea and starting to talk and give voice to female problem specifically related to health. So thank you all, and over to Dr. Dhruvi for final words.
Thank you so much. Our idea was to involve more male doctors who are a part of our panelists. And thank you, Narvaria sir, for doing that. Rucha ma'am, we've always had you, leading us and taking us through the
Anytime, my
process
pleasure.
of health. Now, thank you so much for being a part of this program, and we are calling it a He for She campaign. So I'm going to request all of us who are present here to involve and spread this message to more male physicians and involve them because they are more in number.
Yes.
And we want to propagate this message across everybody who can make a difference in the lives of females and not just doctors. It could be nurses, it could be other stream of people who are very much aware that they have to make a change. So with that, I'm going to thank you all who are present here. I would request you all to just be a part of all our webinars which are upcoming. We have our young girls who are very, very dynamic and are going to take these sessions on type 1, on female leadership, as well as on financial matters for female doctors. So with
Wow.
that, I no longer want to say female doctors, I just want to say doctors.
Yeah.
So thank you so much.
Thank you so much.
Thank you, Vidisha, Dhruvi, and Vipul.
Thank you.
And thank you, Rucha,
So,
for joining
yes, I
me.
just want to say one last thing is that the Obesity India meeting is happening in Ahmedabad this year. And since Dr.
Must be.
Mahendra is the president, we should have a he-she symposium and we can ask Dhruvi to coordinate it. I'm the
Yeah.
scientific chairperson, so Dhruvi, now you're in trouble. So we can do, and so, it'll be nice to continue this and take this forward. So I think because you made a very valid point that there are more male physicians in the country, and if they are not addressing women's health because of, whatever stigmas, the way our social culture is, we are really going to miss out on treating women. So I think, Dr. Mahendra, I'm sure you agree that we can include this some way.
Yeah, I think we need to make Dhruvi and Vidisha the
Conveners for that session.
Thank you.
conveners.
So done.
And from
Okay.
tomorrow we have RRR coming up.
Absolutely, coming out.
Yeah.
So
So
let
I'm
us
waiting
not
for
forget
that plan.
thanking Dr. Vipul Chawda, who actually helped us, execute it and is supporting us in the RRR format of the finance as well.
Oh.
Yes. Okay, great.
Great. Thank you so
Looking
much.
forward. Thank you,
Yeah.
everybody. Thank
Thank
you.
you.
Bye. See you
Bye,
soon.
bye,
Yeah.
bye.
Happy
Thank you.
Women's
Thank
Day
you,
in
sir.
advance to
Thank you,
everyone.
Thank
everybody who
you.
All
joined.
young girls.
Thank you. That was a
Thank
very
you.
fantastic
Thank you. Very
session.
nice. Very informative. Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am.